look at these. Okay, thank you. So good evening, everybody. Thank you for joining us today. So on behalf of the CPS core, myself, Mark Siegel and Sam Simmons, thank you for joining us. And thank you to Blair Spence for joining myself and Mark for presenting today. We wanted to actually just go through and give an HIV snapshot, things that were presented or discussed during IDWeek, which was held in October here in DC. And it's not a heavily HIV focused meeting because we cover everything else, infectious diseases, and we have other competing pandemics and outbreaks that get a lot of airtime. But we wanted to focus in on what was discussed related to HIV. And even though I'm just going to preface it, we basically divided up the sections where there were HIV related topics to review what was presented, to pull out things that we thought would be of interest. I have to say, looking through the things I looked through, it's not all heavy or new research, but I think there are interesting findings, interesting educational components, but where there are some suggestions of areas for potential future research. And so that's what we tried to focus on. So we will go ahead and get started. Dr. Siegel will start first, and then Dr. Spence, and then myself. So,
all right,
Mark, please go ahead.
Let me try and share my screen.
Okay.
So, let's see.
And then just the full disclosure is that we borrowed heavily from the slides that were presented by that were shared by the reviewers. So these slides primarily are from the conference itself. So we've tried, we can always share with your ad where these slides were pulled from. Are you able to do your presentation mode from beginning maybe?
Yeah, so what are you seeing right now?
We see both the next slide and the current slide.
Okay, this seems to happen a lot. So what do I need to do to change that? Display settings?
Yeah, go to end slides maybe. Oh, okay.
End slideshow, yeah.
Yeah, you may be able to do, if you go to your left-hand upper corner to, from beginning. Hopefully that
that's
will
what
do
I did. But that's where it came up. So let me
Here,
try
Mark,
this.
Mark, I have your slides if you want me to just share my screen.
Okay, perfect.
Oh, that works.
That's good.
So are we there?
Yep, perfect.
Okay. So let me just bring this across to where I can see it. Okay. So yeah, similar to what Sibley said. So I looked at 4 different presentations, and yeah, it wasn't necessarily new, but it was stuff that raised interesting questions. So the first was basically out of a presentation which was looking at where the moderators presented some challenging HIV clinical cases. And the first case was of a woman with HIV who'd been diagnosed in 2011 and initially had a CD4 count of 187 with a viral load of about 450,000. And when she was first diagnosed, she weighed 152 pounds. She was started on TDF, FTC, efavirenz, or a triplet. That obviously had some side effects, including vivid dreams. So she eventually was switched off that to FTC, TDF, FTC, and boosted atazanavir. But that caused some jaundice, and so then she was switched over from that to TDF, FTC, boosted darunavir. And she had some issues with that and compliance, and because of compliance and because she wanted a simpler regimen, she was eventually switched over to TAF, FTC, bictegravir, or Biktarvy. And throughout all this, what she had been noticing was a continued weight gain despite her trying to follow a healthy diet and trying to exercise. And this basically was a challenge for the clinician and for the patient. And so basically what we've known for a while that there's been this concern about weight gain, and it's come up not only in patients who initiated an antiretroviral therapy, but also patients who are switched from one regimen to another. And so this was basically a review of about 23,000 patients who are part of the NA Accord cohort. and who had been started or had been antiretroviral naive when they at the beginning, and they were followed prospectively. And what was clearly seen was a significant weight gain in people who started on any antiretroviral therapy, whether it be an NNRTI based, PI based, or INSI based. You know, I don't think that's necessarily surprising initially, because a lot of patients, when they have uncontrolled HIV, have a hypercatabolic state from all the inflammation from the uncontrolled HIV and immune response. And we kind of talk about that as the return to health weight gain that we see in a lot of patients who have started on antiretroviral therapy. But in this cohort, they basically said, you know, there was significant weight gain 3 years after initiating antiretroviral therapy. And, you know, the risk factors that seem to be more associated with more than a 10% weight gain were female sex, having a lower nadir CD4 count, and use of an integrase-based regimen, even though there was not necessarily statistical difference in weight gain between the integrase-based regimen and the PI-based regimen, and with an odds ratio of about 1.37. But there was a statistically significant increased weight gain between those two regimens and NNRTI-based regimens. And, you know, we've actually looked at this, sorry, I'll talk about that in a sec. So when they actually then looked at the different integrase inhibitors themselves, they also noticed that there seemed to be more weight gain associated with people who initiated on regimens that contained either dolutegravir or raltegravir versus elbitergravir. But again, and this is in a population that was initially naive to antiretroviral therapy. We actually looked at this in our patient population, but we actually looked at patients who were virologically suppressed and who were then switched from either an NNRTI-based regimen or a PI-based regimen over into an integrase-based regimen, and also patients who were switched from a TDF-based regimen to a TAF-based regimen. And we did see that in that population where they were already virologically suppressed, so there was no return to health weight gain with that switch. We also noticed that over the first 18 months of that switch, there was about a 2.4 kg or about a 5.3 pound weight gain. That was definitely statistically significant more in the integrase-based regimen than in patients who were maintained on a PI or a NNRTI-based regimen. And the Swiss cohort actually also looked at what happened in their cohort of patients, and again, looked at patients who were already virologically suppressed, who were on a TDF-based regimen. It didn't matter if what the third component, whether it was an NNRTI, PI, or integrase-based third component of that regimen. And when they got switched from the TDF to a TAF-based regimen, they also saw a statistically significant weight gain associated with that. And so, you know, the question still is, like, you know, what is driving this? And some of the theories are that, you know, there's more mitochondrial toxicity in maybe the tenofovir disoproxil fumarate than there is in tenofovir alafenamide. Some people suggest that actually there may be, you know, this subclinical nausea that's suppressing appetite, and so switching from a TDF to a TAF-based regimen may alleviate that nausea to the degree that patients are just eating slightly more, and that's responsible for weight gain. But I think that there's still a lot of research that needs to be done about what the metabolic drivers of this are. And one of the things that they also highlighted is this ACTG study, the 5391 study, where they're actually looking at patients who have had excessive weight gain on an integrase-based and tenofovir alafenamide-based regimen, and seeing what happens when patients are then switched back to a NNRTI-based regimen using doravirine. And this is a study that actually Whitman Walker is doing, and they are actively looking for patients to enroll. It's been slow to enroll because I think those studies, the enrollment criteria were a little bit challenging. They were looking for patients who've had at least a more than 10% increase in the body mass index and had a body mass index of over 30. So they've loosened the criteria a little bit. So they're looking for patients living with HIV who are 18 years or older, who are on an integrase-based containing regimen, whether it be bictegravir, dolutegravir, raltegravir, and have been on that for at least a year with a backbone of TAF, whether it be TAF FTC or TAF 3TC. And they'll then get randomized into 3 groups. They'll either stay on their regimen, that's group 3, or they'll get switched to doravirine with the TAF backbone, and that's group 1, or doravirine with a TDF backbone, to try and see whether, and to see whether there's any reduction in weight over the 48 weeks of the study. Personal experience is one of my patients, one of the first patients I had, who actually had switched from a triplet to an integrase-based regimen and gained 29 pounds in 1 year, and eventually made me switch her back after we looked for other causes like hypothyroidism and diabetes and Cushing syndrome. She eventually made me switch her back to a triplet, and over the course of several years, she actually was able to lose the weight again. So I think it's an interesting study. I'm not sure how much they're looking at metabolic factors that might help elucidate what is actually driving this weight gain, but I think it's an important study, and I'll look forward to the results of this. One of the next cases that they presented was of a patient who had longstanding HIV, had poor compliance. Because of his poor compliance, was poorly controlled, also with a low CD4 count below 200 and with a viral load of about 75,000, who also was struggling with a brain abscess secondary to Mycobacterium avium intracellulare. And that's an infection that, despite antimicrobial therapy, without immune recovery is often not curable. And so had been struggling with, just managing to take his antiretrovirals, managing the side effects, all the other medications for the MAI. And they basically brought up whether this would be a candidate that could be started on long-acting cabotegravir rilpivirine, which has been approved by the FDA, but has only been approved for patients who are actually virologically suppressed on an antiretroviral therapy for at least the last 3 months. And so they highlighted this much talked about study that came out in Clinical Infectious Diseases earlier this year. And this is out of Ward 86 in San Francisco. And this is a HIV clinic that's serving a lot of the underserved and underinsured or public insured patients and living with HIV. A lot of them have unstable housing. A lot of them have substance use disorder and mental illness. And basically they took 51 patients from this clinic and started them on long-acting antiretroviral therapy. The criteria for enrollment was that they couldn't have any mutations to rilpivirine. They were allowed 1 or less integrase mutations, and they didn't have to be virologically undetectable at the time that they were started. And of the 51 patients that they actually started, 15 were viremic at the time that they were started on long-acting cabotegravir rilpivirine. And what they noticed is that all the patients who had been virologically undetectable when they were started on long-acting cabotegravir rilpivirine remained undetectable at the 48-week mark. Of the 15 patients who were viremic, 12 of them became virologically undetectable, and the majority of those became undetectable within 28 days of starting on long-acting cabotegravir rilpivirine. Even the one person who did have a integrase mutation at enrollment, and the other 3, even though they didn't become virologically undetectable, had at least a 2-log decline in their viral load. And one of their suggestions is, maybe this is exactly the population that we should be targeting, because it's a population that is struggling to take the antiretroviral therapy because of unstable housing, because they don't have anywhere safe to keep their medicine, because of possible stigma associated with other people seeing them take their medication. One of the things that was pointed out is they threw a lot of resources at this. They had a clinical pharmacist who basically oversaw the program, who basically checked in with the patient 7 days after their injection, who basically followed up with them to make sure, gave them appointment reminders, and if they missed their appointments, kind of made sure that they came back for the reschedule the appointment. So, it is resource intensive, but at least as a proof of concept, I think it's interesting. And so going back to the patient, that they actually took this patient who had the viral load of 72,000, and they did start him on long-acting rilpivirine cabotegravir, and he became undetectable within a month of starting, and as of the time of the presentation had been undetectable for 5 months, and was now was able to tolerate his therapy for his mycobacterial brain abscess, and was also able to get started on therapy for his chronic hepatitis C. So, just a single case presentation, but at least again, a interesting concept that we may consider broadening the criteria for who is eligible for long-acting cabotegravir rilpivirine. There was also a debate between two moderators, two discussants about the same topic. It was a pro-con debate, and the pro initially before the presentation, they polled the audience about whether the audience would consider starting someone with a not virologically not suppressed HIV on long-acting cabotegravir rilpivirine. And at the beginning of this debate, 55% of the audience members said they would. The person who gave the cons on this was Dr. Barra from University of Nebraska. And she basically brought up that one of the issues that we saw in the Atlas 2M study, which was comparing 8 weeks of injectable cabotegravir rilpivirine to every 4 weeks, and looking at virological failure, is there were more people who failed in the 8-week arm than the 4-week arm. There were actually 9 failures in the 8-week arms versus 2 in the 4-week arm. What was more concerning is out of the 9 failures, 7 actually failed with either resistance mutations to rilpivirine or integrase mutations. And that is something that also, she pointed out, the mutations that were developed, that were seen, were mutations that actually cause cross-resistance with other medicines in the same class. So for the NNRTI-based mutations, these are some of the mutations that they saw, and you can see the M230L mutation that 2 patients developed, knocked out all, made the HIV resistant to all the available NNRTIs that were available, including doravirine, which is the NNRTI which has the highest barrier to resistance. And it was similar in some of the integrase mutations that we saw. So the Q148 mutation that was seen in several of the patients who failed also caused resistance across the class, the integrase class. And so basically just suggesting that, this is, we are running the risk of seeing more of these resistance mutations if we don't pick our population wisely. And what was interesting at the end is they took a poll at the end, and the audience had actually changed its opinion. And at the end of the debate, only 44% of the audience still thought it was a good idea to start patients who were not virologically suppressed on long-acting cabotegravir rilpivirine. So I think one of the things she brought up is the issue with obviously long-acting cabotegravir rilpivirine is the long half-life, especially of the integrase inhibitor, the cabotegravir. And studies have now shown that cabotegravir has a tail of somewhere between 3 years in men and 4 years in women. And because it has such a long tail, you get detectable levels of cabotegravir that kind of hang out in what we call this resistance zone, where it is below the threshold needed to suppress the viral replication. And in that time, as the virus starts replicating again, allows for the development of these resistance mutations, compared with oral antiretroviral therapies, where if someone's not compliant or someone just decides to stop taking the medicine, usually the medicine, because the half-life is much shorter, the time in that zone where you are at subtherapeutic levels of the antiretrovirals is much shorter, and therefore there's much less chance for developing resistance. And to kind of highlight that, she kind of the discussant brought up the data from the Biktarvy studies that have been done, and we now have data out to 240 weeks of 5 years of data And even though there were some patients in the study who met criteria for resistance testing, there were no patients who were tested who had any integrase or bictegravir resistance mutations detected, and basically suggesting, the oral antiretroviral therapies may be more forgiving in terms of the development of resistance, especially in patients where you're not sure about their level of compliance. So just was food for thought. The last two presentations were from the presentation about optimizing HIV care and prevention. And the first was basically the results of a national survey that has been done. Let me see where it was being done out of. It was done out of UNC. And it's a national survey of women who related to their awareness and interest in PrEP. And this was basically because women account for 20% of incident infections in the US, but are only making up 8% of PrEP users. And this is based on data from 2021. And this is actually an interim analysis. This is a study where they're hoping to enroll 2,000 women. And the criteria is they have to be 18 years or older, assigned female sex at birth, have had penetrative intercourse in the last 6 months, and be either HIV negative or have unknown HIV status. And the sample size in this was a little skewed. The majority of the patients were from the West Coast and not from the South, where the majority of the incident HIV infections are being detected. 55% of the respondents were Black, 32% identified as Hispanic. And when they looked at risk perception, even though the minority said they consistently used condoms, only 16% consistently used condoms, and only half had ever had an HIV test, the majority thought their risk of acquiring an STI or HIV was low, with 85% saying they were only somewhat or very unlikely to acquire HIV. So then when they looked at the results of the survey, when they looked at PrEP awareness, it was encouraging to see that 70% of the respondents had heard of PrEP. And what was interesting is that it was actually the awareness was greater in the older population, and the population was 40 to 49, than in the population of 30 to 39, and the population in the below the age of 30. When they asked about whether the population had ever heard of long-acting PrEP, and this was actually a survey that's done in October, November of 2021. So this was actually before long-acting cabotegravir was FDA approved. And when they looked at that, 50% of actually had heard of long-acting PrEP. And in this point, actually it was reversed from the previous, where actually more of the younger population had heard of long-acting PrEP, with 55% of the respondents aged 19 to 29 saying they'd heard of PrEP versus 41% of the respondents in the 40 to 49-year-old age group. The minority, only 30% had ever talked to their healthcare provider about PrEP. When they looked at PrEP usage, it's similar to what they prefaced before, that 19% had ever used and only 9% were actually currently using PrEP. And when they looked based on racial demographics, 49% of the Black Hispanic respondents said they'd ever used PrEP, and only 14% of Black non-Hispanic women had ever used PrEP. When they looked at willingness to use PrEP, it was actually encouraging, and looking at willingness to use long-acting PrEP, actually 66% said they would be somewhat or very likely to use PrEP. But then when they looked at the reasons why they said they would be willing to use PrEP, even though the number one reason picked was to prevent HIV, the second most common reason that was picked was to prevent sexually transmitted infections, with 40% of respondents responding to that. Obviously, they not being aware that there's no protection against sexually transmitted infections with long-acting cabotegravir. When they gave them the choice of whether they would, if they had a choice between long-acting injectable PrEP or a pill, the majority chose long-acting injectable PrEP, although 29% said they would, if they're given the choice, they would not choose either. And when given a choice of any form of prevention, the majority still just chose condoms as their preferred method of prevention, with then 24% choosing long-acting injectable cabotegravir or PrEP, given by a healthcare provider, and then 9% saying they would prefer it if it was something that they could self-administer. So I think, this highlights that, women, there's still, a lot of work that needs to be done to try and encourage women who are at risk to have increased awareness of their HIV risk, and also to maybe try and see what we can do to encourage the use of long-acting injectable cabotegravir in women who have risk factors or indications for PrEP usage. And then the last slide, so I know I'm going a little late. This was basically a study out of a modeling study out of Harvard Medical School. So this was a Monte Carlo microsimulation where they basically wanted to simulate the impact of strategies to improve testing, engagement in care, and viral suppression across the HIV care continuum on life expectancy. And they basically they were looking at a primary outcome of life expectancy from patients starting at age 15. And so what they did is they used the data that was available from the CDC as of 2019 to come up with their kind of status quo care continuum, where they started with 100% of people who had HIV, and then of those, they extrapolated how many would actually have been diagnosed with HIV, which was 82% for Black MSM and 90% for white MSM, and then of the total, 62% would be engaged in care for the Black MSM, 72 of the white MSM, and then down to only 51% of the total MSM living with HIV having a viral suppression if they were Black MSM, 62% if they were white MSM. And so then they wanted to see what they could do to actually, if they modeled increasing or doing different strategies to increase, increase the, they had 4 different strategies that they were looking at. So the first was actually looking at how to increase patients diagnosed with HIV. So they modeled basically performing annual HIV testing in the population, and thereby raising the patients diagnosed with HIV up to 100%. And by doing so, would, even if they left the percentage of patients engaged in care and patients with viral suppression the same, that would increase the absolute number of patients engaged in care and viral suppression. The second strategy was to increase to 95% patients engagement in care over time. And this wouldn't change the percentage of patients who are diagnosed with HIV, but it would increase the absolute number of patients who then were virologically suppressed. The third intervention was to increase the viral suppression rate to 95%. And this would not necessarily change the numbers of the percentage of patients and the absolute number of patients diagnosed with HIV and engaged in care. And the fourth intervention would be doing a combination of all 3 of these interventions. And so what they did is basically looked at the status quo. And what we have here is the gray bars that you see are patients before they are diagnosed, the time from 15 years old to their diagnosis. So in the top bar in the status quo, this is someone from age 15 to about age 28, and at age 28 is where they are diagnosed with HIV. And then the yellow box is basically circling the time that they're living with HIV before they're diagnosed. So the left side of the box is when they're actually infected with HIV, and the right side of the box is when they actually become diagnosed with HIV. And then the darker proportion is the time that they are actually on therapy for the HIV. And they had modeling data and they used life expectancy for Black MSM of 52.2 years and life expectancy for white MSM of 58 years. So a difference in life expectancy of 6.3 years. And then they looked at the effect of each of the individual interventions. So annual testing would increase life expectancy by 0.6 years, in 95% engagement in care this is just for the Black MSM population. 95% engagement in care would increase life expectancy by 1.4 years, and 95% viral suppression would increase the life expectancy by 1.1 years. Combining all 3 strategies, their modeling data suggested they could increase life expectancy by a significant 3.4 years for Black MSM. And when they looked at white MSM, it was less. It was an increase in life expectancy of 1.6 years. And when they looked at the single most important intervention that they could do in the Black MSM population and the white MSM population that would increase the life expectancy, it was the increasing engagement in care to 95%. So I think this highlights, it's a Monte Carlo microsimulation, so it's modeling data, but it is something that I think we are trying to figure out how to do better, engaging our patients who are lost, who are not engaged in care. And I think, it is something that I think would eventually have benefits in life expectancy. And it's something that I think, clinics could do, could focus on as a strategy to try and bring more patients back into the clinic. So I'm sorry, I went a little over my 10 to 15 minutes. So I will stop my share and I will pass it over to Sebly or Blair, and I'll take any questions, I think, at the end of the 2 other presentations.
Unless someone has a burning question now while Blair pulls up her slides. Thank you, Mark. That was really great.
Sorry, I went a little long.
All right. So as I'm pulling up the slides.
Yeah, and then feel free, folks, feel free to type into the chat if you have a question that Mark can address for you as well, just so that we don't run short for time for questions at the end. Go ahead, Blair.
Okay, so I think mine is fairly short. It should only take 10 minutes or so. And as Dr. Siegel and Dr. Kasai mentioned earlier, a lot of the information in the sessions that I looked at wasn't necessarily new information, but I tried to pick out things that I thought were either A, interesting, or 2, may spark discussion, or at least had made me think about additional questions in my mind. So the first one was HIV and COVID, and I wanted to start with talking about that and a few of the interesting things that I thought were interesting. And so, one of the, did I skip? One of the biggest questions since the beginning of the pandemic, at least in the HIV research community, was, are people living with HIV at a higher risk for severe or fatal COVID, and or are they at more risk for getting COVID itself? And although now we have about 2 years worth of data, studies have been variable in outcome, but also the methodology has been different by the studies. But they presented this meta-analysis that looked at COVID-19 outcomes in people living with HIV, and they pulled about 2 years worth of data and about, I think it was 32 studies that they used in this analysis. And when they did their adjusted analysis, they actually found that there was a trend towards increased risk of severe COVID-19 in people living with HIV and an increased risk of death. But one of the major limitations of this analysis was that they really were not able to look at the impact of antiretroviral use, the CD4 T lymphocyte count, and or HIV viral load. So that HIV related factors, you can't really assess with that. And then they also went and presented data from the WHO global clinical platform for COVID-19, which looked at data from COVID-19 hospitalizations across 38 countries. And they ended up with almost a little bit more than 16,000 people that were living with HIV. So it was actually 16,995 individuals living with HIV. But note that this was not well dispersed among different settings. So it wasn't heavily represented by high or middle income countries, and African countries made up about 96% of those living with HIV. And the authors found that there was significantly higher mortality risks for persons living with HIV that were hospitalized in this setting. But those risk factors were mainly related to comorbidities, which we've seen, like including age, male sex, diabetes, hypertension, but also tuberculosis, kidney disease, and malignancy. And interestingly, when they did an exploratory analysis of HIV treatment-related factors, they found that those that were on antiretroviral therapy and had viral loads less than about 1,000 at admission had lower mortality and were less likely to have severe COVID-19 disease at admission. And then finally, among people living with HIV, as we've seen through studies that have kind of trickled down over the past 2 years, traditional risk factors such as hypertension, diabetes, age are important risk factors for developing severe COVID, or at least COVID severe enough to require hospitalization. And there were also trends toward increased risk for severe outcomes with lower CD4 counts. But really the threshold for that level is less clear. And then just to switch gears a little bit, but still stay on COVID-19 and people living with HIV, I thought the next speaker in this session had quite interesting things to say about COVID-19 viral dynamics in immunocompromised individuals and those living with HIV. Because oftentimes I find when I'm reading these papers looking at COVID-19 in immunocompromised individuals, there are not a ton of people that are living with advanced HIV or AIDS, but it's other immunocompromised individuals. And so the presenter actually did their own semi-systematic review of published cases of people living with HIV. And they looked at viral shedding in immunocompromised hosts. And as you can see, from what we know previously is that people with that are immunocompromised have prolonged viral shedding, but you can also see that with people with HIV and advanced AIDS. But one of the big concerns with these prolonged periods of replication is the development of viral mutations in the host. And one of the interesting things that, and I probably should have put a bullet on here, that the speaker talked about is where these mutations occurred. And when these mutations occur in these immunocompromised hosts, they can occur throughout the virus, but they tend to occur on the spike protein, which has, I think, interesting implications and things to think about. And so with regards to viral shedding, they did present one study that looked at viral shedding among individuals, both with and with HIV, that was set in South Africa. So they had about 257 people that presented with symptomatic COVID-19. Among those, a little bit less than half were living with HIV. So it was 102 of those individuals versus 155 HIV seronegative individuals. The majority of people were on ART, so about 84%, and about 60% or 59% had a viral load of less than 200, or excuse me, less than 400. Sorry. But the persons living with HIV had a median positivity time of 15 days versus 11 days for people that were HIV negative. And then, of course, as we would expect, lower CD4 count was associated with longer shedding. And then this longer shedding also tended to occur in those without an anti-spike IgG. Because of lack of time, I did take some of the slides out of the presentation, but also this session was very interesting in that there was also a presentation from Dr. Castell during the session that talked about disruptions in the HIV care continuum, but for the sake of time, I move past that. The next session that I pulled a couple of slides from were updates in HIV treatment and investigational long-acting ART. So a big focus of the HIV state-of-the-art session was on long-acting HIV treatments, as well as those for PrEP. And I think they're really emphasizing that, this is a shift in the way we're thinking about delivering care for people living with HIV. So I've just picked out a couple of selected drugs. So the first is lenacapavir, which is given as a subcutaneous injection. It's actually approved for treatment of heavily treatment experienced individuals living with HIV in Europe, and is currently under review here. It has a unique mechanism of action in that it's a capsid inhibitor and can block HIV assembly at actually more than one step. And one of the nice things about it is that it has extremely long half-life and can be given at a Q6-month frequency. So in this study, patients were treated with lenacapavir plus an optimized background regimen. And they found that those in the lenacapavir group had a substantial reduction in viral load versus those with placebo. Then they took a bit of time to talk about islatravir, which I think we've all been following quite anxiously or not, but following. So islatravir, it's an oral DNA chain terminator that was under investigation for HIV prevention, given once monthly, as well as an oral weekly version given in combination with a Merck long-acting non-nucleoside reverse transcriptase inhibitor. And I'm blanking on the number for that. But most of you know that islatravir was clinical development was placed on hold by the FDA about a year ago because of reports of decreased lymphocyte counts in individuals taking these regimens. And they found that statistically significant decreases in lymphocyte counts occurred in those that were taking these regimens, but true lymphopenia was actually rare in these studies. However, in September, the FDA did release the clinical hold on islatravir for once daily oral administration and once weekly administration. And so the reason for this was that these proportional decreases in both the CD4 and lymphocyte count were found to be dose dependent related to the islatravir dose. So they actually reduced the dose of islatravir from 0.75 milligrams weekly to 0.25 milligrams as a maximal weekly dose. So now the planned oral treatment of islatravir with the oral formulation of lenacapavir is planned to open soon, but the prevention trials remain on hold. They also talked a bit about development of implants, particularly with tenofovir or TAF, and they put like a little cartoon here of an example of what the delivery device would look like. They talked a bit about the issues with skin necrosis related to use of the tenofovir in some of the animal studies that were done. But they found that the skin necrosis was really related to the drug release rate with the tenofovir. And those that released the drug at less than 1 milligram per day were associated with less toxicity or little toxicity. And those are the implants that remain in current clinical development. And I thought this was a nice kind of graphic and way to think about the long-acting antiretrovirals that are currently in the drug delivery pipeline, because I think it provides a nice kind of roadmap to think about what's to come and how do we think about implementing some of these treatments if and when they become available, or patients would be interested in those. So one would be the microneedle patches that can be applied transcutaneously that produce like a subdermal depot rather than an intramuscular depot and could be applied by the patient. There's new implant technologies, some that are biodegradable, other strategies being used to reduce the injection volume of intramuscular and subcutaneous injections. What I found interesting, and I didn't really think about before, were gastric reservoirs, so that you can swallow whatever the reservoir could be, and it would be released from the stomach slowly, allowing the regimen to be given like every 1 to 2 weeks. And then finally, other combination technologies, including like a contraceptive given with daltebarine as a vaginal ring are being developed. And, these are applicable both to treatment of HIV with ART as well as with PrEP. And then finally, I thought that this session was interesting. It talked a lot about PrEP and PrEP delivery models. So really thinking about how are we giving PrEP, and are there better strategies to give PrEP to patients and people that are interested in it. So one study that they pulled was originally actually presented at IAS, and then they highlighted it again at IDWeek. So this was a study done in Kenya that compared standard of care PrEP delivery with the typical every 3-month clinic visits combined with clinic-based blood testing for STIs and lab monitoring versus 6-month clinic visits with a blood-based home test or oral testing. And their primary outcomes of interest were not incident HIV infection or STIs, but they looked at performance of HIV testing in the prior 6 months, PrEP refills at 6 months, as well as PrEP adherence. And they really found no difference in any of their primary outcomes in any of the groups when they compared it to standard of care. So those that had been tested for HIV refilled their PrEP or their adherence to PrEP. And then finally, I just wanted to close with this study that they presented about PrEP, and it's the Iowa teleprep model that utilized like a mobile PrEP visit. So it would be conducted using a smartphone or a computer, and they specifically highlighted this video visit app and stressed the importance of this specific platform to be used to be given for the PrEP visit. And then they did local lab testing and medications by mail for PrEP delivery. And they used a collaborative pharmacist practice model where where pharmacists would be in collaboration with physicians or licensed healthcare providers to be able to provide PrEP. And then later they actually implemented using mail delivery labs as well. And you can see from the map of the state, for those of you not as familiar with Iowa as I wasn't, how diffuse the lab sites were. And you can see that there's lots of areas where there may be difficult for people to access care. And when they looked at the populations that they reached, at least with the initial video visit, they did reach target populations. So they reached young people aged 18 to 30. They were able to reach rural areas with about 17% of them with rural areas. A lot of them were in small urban areas. And they were able to reach some uninsured populations there. As Iowa is a state where there's no Medicaid expansion. They also looked at adherence to the follow-up lab testing within the Iowa teleprep model. And they found that the adherence with guideline recommended baseline and follow-up testing for HIV, creatinine, STIs was fairly good in their model, which I think is kind of interesting, particularly, in contrast with some of the things, at least, I've seen observationally with testing and telehealth and other settings. So I think those are the slides that I have, and I will close out and let someone else.
Yeah, great. Thanks, Blair. And yeah, you're still sharing, but please do put questions into the chat for Blair, and I will try to fly through some of these slides and maybe not all. And I'm happy to share my I'm happy to share the slides with everybody. So the sections that I looked at were HIV, basically HIV management, including comorbidities, the gender diversity and contraceptives, HIV and STD cases, and HIV policy and advocacy. So for the HIV management, again, these are the individuals whose slides I've borrowed from heavily, who were running that session. And the slides are very busy, but I think I can quickly walk you through. So we've heard a lot about PrEP. We have very many or quite a few excellent options. So TDF-based oral PrEP, TAF-based oral PrEP, with obviously studies ongoing for women, and now some, on-demand PrEP options, as well as long-acting CAB. And I think the questions that I think are raised in my mind from some of these data. So is number one, that CAB has been demonstrated now to be superior to TDF-based formulations, both in cisgender men as well as transgender women. So it is superior, not equivalent, with 13 cases with the long-acting formulations compared to 39 in the oral formulations, clearly favoring CAB, and yet our standard of care remains these oral therapies, and our expansion to long-acting agents is still very limited. So I highlight that. We also now have data in women demonstrating the same. One case in the long-acting CAB versus 36 with TDF-FTC, demonstrating superiority. And then there's the, what could potentially be the downside. So the downside, and I think this exists also probably to some extent for the oral regimens, is that we really have, with the testing that we use, there's delayed seroconversion with the long-acting CAB. And so it's imperative that we include direct testing, nucleic acid testing as part of our HIV screening. And so the guidelines have been updated to reflect that. So in addition to your 4th generation antigen antibody testing, you're also supposed to do RNA testing, but there are concerns about delayed seroconversion and then implementation of this with RNA-based testing. Some are using pooled RNA testing to just because of cost-related issues, etc. And then also the very, very long tail that Dr. Siegel spoke of, which is different in men versus women. So for in the PrEP context, it's about 10 months for males and 15.5 months for females. And so, covering this tail with an oral regimen is something that some would consider, especially if individuals are off CAB-based PrEP, but are still potentially in a high-risk situation with serodiscordant partners, etc. So I think the potential areas of research that I really thought would be interesting for people to consider is really looking at what is the incidence of PrEP failures for us in the DMV area, and really some of the implementation research on long-acting PrEP, including long-acting, once we get people on long-acting CAB, failures, resistance, and what do we do with this tail coverage. Then there was like a kind of a very enticing conversation that I think we've heard again about rapid ART initiation. And I know that there have been people within the bigger CFAR group locally that have looked at this very carefully. And really, I think there really are very few reasons to not start ART early. Because the medications that we have are very robust and can be started empirically and safely while we wait for labs to come back through. And so there really was an emphasis on, we really can push the needle on earlier therapy, earlier engagement, quicker time to viral suppression, hopefully fewer transmissions. And here I thought the potential areas that we could really focus in. I know there are a lot of people in our community who do work on the continuum of care and looking at durable viral suppression. But then really, it's really what are the service delivery models? I think we're at the time that these should be the discussions we're having. How do we do this with telehealth? And how do we scale up same-day ART initiation? And really thinking about the syndemics that maybe are what are going to be kind of our Achilles heel. So the mental health problems that we have to address, the substance use disorders that we also have to address, issues related to stigma that we need to overcome. So really considering the syndemics and really having the research that we do be multidisciplinary and trying to address these holistically. The next session I looked at was related to HIV and comorbidities by this group of investigators and clinicians. And I'll start, one of the areas, the focus areas was around HIV and aging. And there was a really beautiful talk that was really case-based, was talking about someone with very frequent falls, a lot of polypharmacy, had the beginnings of what clearly could be demonstrated as cognitive decline, and where the clinical needs were very much changing. And so the person really highlighted, what do we not know? Where are we failing? And some of it is in failing to assess for cognitive function, functional status, not addressing sexual health, substance use in our elderly, in our aging population of persons living with HIV. So these were things that were highlighted that I think provide opportunities for us to look at these very systematically, see where are our failures, and try to make sure that we actually are promoting healthy aging for our persons living with HIV. A big focus also on understanding loneliness, some of the mental health components that go into as persons now are starting to survive and outlive their compatriots who also may have been living with HIV. So the possible areas of research I thought we could consider were really looking at what are the needs of older individuals living with HIV in DC, how well are we doing and implementing some of these kind of what should be standard of care, preventive and screening modalities, and what interventions can we put into place to improve health outcomes as our with an aging community of persons living with HIV. The ART and weight gain, I think we've discussed quite a bit. So on the left upper hand corner, you see basically the weight gain that occurs with antiretroviral therapy, much more so with dolutegravir and TAF-based therapy, some differences between men and women. But I think the next part that I thought was really interesting in this is that with a 5% increase in weight gain, you also have concomitant increased risk for development of metabolic syndrome, which is then what really sets you up for increased risk for cardiovascular disease. And so they showed this very nicely. But then here, what I just pulled out, and one of the studies actually Dr. Siegel mentioned already, are opportunities for us to refer to active ongoing ACTG studies. So the DO-IT study is using doravirine and NNRTI in place of an integrase inhibitor. And so I certainly will look to our colleagues at Whitman Walker to refer individuals to this for the study. And I'm not sure if this study will be open. And this one is really focused on transgender women who may be taking gender affirming hormones. And in that setting, we know women will gain weight. And the weight that they gain is increased fat. There'll be loss of lean body mass. And there's also increased lipids and glucose in the setting of using gender affirming hormones. And so it's not known how much the ARTs and initiation of ART will contribute to metabolic syndrome, weight gain, et cetera. And so this study is looking for transgender women who are newly starting antiretrovirals to be enrolled into either darunavir versus dolutegravir, bictegravir-based therapy. And I don't know, Mark, if you know if this study will be ongoing as well locally, but this I think will be a very important study as well for the transgender community for us to understand what we should do. And as we continue to support women who want the gender affirming hormones, but who also may have additional complications from antiretrovirals. There was some discussion on the care continuum among transgender women. Again, transgender women having lower overall viral suppression compared to cisgender men and women. And then in the Ryan White program, again, there are additional social determinants that contribute to further decreases and lower levels of viral suppression. Some are structural, such as housing, but also younger individuals, African-American individuals. And so looking at all of these, what the group was recommending was really to make sure that we take a very holistic approach to service delivery, really trying to factor in all of the other things that may bring transgender women into a facility that go beyond just HIV, and to really make sure those are well integrated. They really even talked about like the setup of their clinic, with their bathrooms, etc., trying to make sure that you really have a warm and accommodating environment. Again, these are things I think that we do need to look at. Looking at the care continuum in that subgroup, I think will remain very, very important. And then the contraceptions relate for women. Again, there are a lot of opportunities to provide hormonal therapies safely. What was brought up is that there are higher rates of comorbid medical conditions that arise among women. And these are data from the MAX and Ys, but generally speaking, comorbidities arise early, including in the reproductive years. And so sometimes we may need to consider what comorbidities individuals have as we select hormonal contraception for women as appropriate. And so here I was thinking that some of the things that we really could look at probably carefully are comorbidities among women with perinatal HIV infection, and then also consider some of these other reproductive health care needs of women in the context of our research. This one I just pulled out just because it's interesting. So this is for transgender men in this context where we're giving testosterone therapy to support gender affirming hormone use. We are still, if you are using kidney function estimating equations that include the sex assignment at birth, then you will end up with a different estimation of glomerular filtration rate, which is not appropriate. And so since you're giving the hormones, you would need to make that change in the formula that you use. And that would, for example, enable you to use a TDF-based PrEP regimen, for example, for someone who wants it. So this was just a little tidbit that I picked up on. So a lot of talk about STDs. As you can imagine, there was a session on how to actually just test for syphilis. We spent an hour of that, and you'd think everybody would know that by the time they're going through fellowship and practicing, but it's unfortunately not the case. So going over this is very important. So it was case-based. Things that I took away: that you could have multiple primary lesions. They could be painful. Don't forget, you can have co-infections with herpes and other things as well. Treat early. You don't need to do CSF testing for otosyphilis or ocular syphilis as long as you don't have neurologic signs and symptoms. And they reviewed carefully the appropriate therapies that hopefully everybody will stay up to date with. And then obviously the issues of congenital syphilis are high priority for everybody. And so really the screening in the first trimester, repeat screening at the second trimester or the third trimester, and then at delivery if someone remains at high risk. So for high risk individuals, it's 3 times testing. And how well are we implementing this? And then giving the second dose of penicillin for a woman who presents with secondary syphilis was another thing that I thought was really relevant. And for congenital infection, only about 60% would be symptomatic at birth. So the importance of getting pediatric infectious disease colleagues on board so that they can continue to monitor a child and do the appropriate testing. So possible areas for investigation here: are we treating with timely and appropriate antibiotics? Can we decrease the rates of syphilis? And also thereby contribute to AHE efforts, knowing that our caseloads are going up? And then how well are we doing with testing pregnant women during pregnancy, at delivery, and with referring the children as appropriate? And then the last thing, and I think Blair, you presented something about PrEP in Iowa, and you said that people were doing a really great job with overall testing for HIV and for genitourinary disease, but the extragenital testing that you showed was in the 50% range. And so this just highlights that, you know, we would miss about a third of cases of extragenital disease in both in men who have sex with women and women who have sex with men if we did not do the testing. So we know that this is something that maybe people focus on among MSM, but really it's all populations. The gray bars that you see are the cases that would have been missed of gonorrhea on the left and chlamydia on the right if you did not do the extra genital testing. So here I thought the areas of investigation could be looking at how routinely whether we are routinely screening for extragenital gonorrhea, chlamydia, and whether there are differences by different population types. What's the prevalence of extragenital gonorrhea, chlamydia among women in the DMV, or maybe our older populations in the DMV? And then opportunities for some implementation science research, looking at concurrent STI and HIV prevention, expedited partner therapy. Are we doing it? Now, how well are we doing with that? And then there were also some discussion on doxy-PEP. So using doxycycline 200 milligrams within 72 hours of condomless sex, which decreases STIs among men, and transgender women, but there are no data in women. And so is that something that potentially could be explored locally? I think that's, mycoplasma. Mycoplasma exists. We don't think about it very much, but we probably should. So I just pulled the prevalence from different settings. It's anywhere from like 12% to almost 25%. So something to think about if we're not curing people with their symptoms with our usual therapies. And then opportunities, again, to refer people to trials who fail our initial empiric therapies. Some discussion on monkeypox, and I know there are people who will be doing some work locally on monkeypox, but also I wanted to just pull out the opportunity to refer individuals for therapy with TPOXX in the right context. And then lastly, the HIV and policy and advocacy. So there really is a call for increasing our investments to end the HIV epidemic, to fund a national PrEP program, which I thought was great, really focusing on a diverse workforce. And here are the potential areas for research where obviously, addressing structural barriers, some of these through innovative service delivery models, implementation, taking up the implementation challenges around the things we've discussed. But the message from Senator Doug Jones from Alabama was kind of like he was really applauding a lot of the work that ID physicians have done. But the message I took away from him was when he said, don't be shy. Thank you for all you do, but just go out there and talk about what you do. So with reporters, with, Capitol Hill's just down the road. So he was asking us to be advocates, both for ourselves and to talk about the work we do to try to secure additional funding to keep doing what we're doing. So that's it from me. And I know I've kept us very late and a lot of people are still here. So if there are any burning questions, maybe we can take a couple of questions and then obviously the slides will be there for everyone to look at after.
Well, I just have a quick comment if I could.
Sure.
I just want to thank the three of you for just outstanding presentations. Many of us don't have the opportunity to go to these meetings, and to have it all crystallize what's new and exciting is really a huge contribution. That's why I think everyone's staying till 6:15, 6:30 and would stay, because we want to learn. And those were great presentations. Each and every slide was valuable, and I just wanted to express my gratitude. I learned a lot.
Yeah, thank you.
Thank you.
Yes, George.
I just want to echo from the community perspective that I found this very interesting tonight, and I really appreciate all the hard work going into putting these presentations together. I would just ask that we start calling Mpox by its official name now and stop using the name that was used before with the official change from the World Health Organization.
Yes.
Thank you.
Yeah, thank you. Any other questions, comments? So hopefully there's some food for thought for future areas of research. Please use these to, if as you talk to junior investigators. I know a lot of our senior investigators are very heavily invested in ongoing research, but we really do need to keep new folks coming in and working on these topics. There's still a lot of work to do, and if we don't have the expertise, certainly I think we need to find people who can help support us to really investigate these areas where there are gaps that we all tried to highlight. And then also for the work that does speak to some of these gaps, really making sure that we highlight what we do locally, because I think we do a lot of things very well locally that should be we should be on these presenting panels. Okay, all right. Well, thank you, everybody. Thanks for staying so late, and have a good evening.
Thanks. Bye.
Okay, bye-bye.